Okay, so if you're sitting on the fence and you don't have a clear and obvious reason to refer yet, you can try some medical treatments and then recheck. Many of the medical treatments that we're doing anyways are going to help stabilize a horse in preparation for surgery. We want them off feed to avoid more bulk, making the dam bigger and the intestinal tract more distended. And we need to keep the horses safe and quiet to avoid them injuring themselves. We can decompress the stomach and give the abdomen a bit more space for the viscera to move into a normal position, or use nasogastric intubation to add moisture to the ingesta. There's also a gastrocolic reflex that might help in some situations by filling the stomach with 6 to 8 liters. The peristalsis in the colon actually strengthens and may help with gas or impactions. You can also administer fluid per rectum when you know the impaction is present, literally attacking the problem from both ends. Intravenous fluids may also be essential in your initial treatment, less because it's going to help the colic directly, but more because it's going to improve perfusion and help the whole body function, flush out any buildup, and improve the blood pressure. A horse in shock is not a good surgical candidate, so if it needs some systemic support, give it. It can be a bit overwhelming to try and decide which treatments to give and when. And I break my treatment plan down into levels. First line treatments are those that I've likely already administered during the examination. I like xylazine and butorphanol for my sedation, as I get a short-acting sedation with some mild analgesic effects. And yes, alpha-2s and opiates can slow gut motility, but pain slows that motility down way more. I will do just about anything to try to break that pain spasm cycle, even if it means keeping a horse on a CRI of alpha-2s overnight under close supervision. Depending on where you practice, you or even the owner may have already administered some nonsteroidals. In Canada and the US, we use a lot of flunix and meglumine first, which I know is a bit taboo in other areas, so beware. And other regions may use phenylbutazone or metamizole, which is dipyrone. And if you have them, great. They're really good first-line options because they're a little bit milder and they're less likely to mask a severe or surgical colic. Your first-line therapy with enteral fluids is just water and some electrolytes. You don't necessarily want to use pure water because it might cause a hyponatremia. So even just a couple of tablespoons of table salt is a good thing to add. My second-line treatments are used only in some cases, and this is when I might use my Buscopan if I haven't already used it in the rectal examination. I've also included it here because there are some cases where we may want to use Buscopan repeatedly. If the horse is still very painful or you want to see the pain spasm cycle broken, this is when you can use the Banamine or the Flunixin if you haven't already. Caution must be used if there's already NSAIDs on board, as you can cause a severe GI upset or even colitis and ulcers. So I try to ensure that there's at least 6 hours between my NSAIDs, preferably at least 8, but I know that it's happened on more than one occasion where 2 doses have been doubled, and it doesn't appear to be critical in most cases. Once you have your analgesics on board, you may want to use some longer acting sedatives like ditomidine, especially if you'll be doing multiple nasogastric intubations or if the horse is still really throwing themselves around. You can also combine your sedatives intravenously and intramuscularly to give a prolonged response. This can be really helpful if you're going to be leaving the owner and heading to another emergency or appointment and not able to check back in for a little bit. Your nasogastric treatments might be perfect times to use additional additives like lubricants or laxatives to help impactions resolve.